Next presenter is Dr. Mili Mandal.
A very good morning. This is Dr. Mili Mandal, and my topic of presentation today is Unveiling the Mystery, Diabetes, Drooping Eyelids, and Missing Brain Arteries. So according to World Health Organization, the total number of diabetics have increased to 422 million. There have been a 3% increase in diabetes mortality and about 2 million deaths due to diabetes and its complications. So if I were to talk about the complications of diabetes, diabetic neuropathy is one of the most common complications, and among them, oculomotor palsy is one of the most frequent neuro-ophthalmic manifestations. So what is the etiology behind the oculomotor palsy? It is hyperglycemia-induced damage to the nerve cells, resulting in neural and ischemic change. So here I present you a case of a 61-year-old female who presented to us with acute onset right upper eyelid ptosis for 7 days, which was non-progressive without any diurnal variation. There was a positive history of headache and 2 recent episodes of syncope.
Dr. Mili, can you just hold on for a minute because there's no display here?
Okay, sure.
We'll give you extra time, don't worry.
Okay, ma'am.
This display is not functioning.
Okay, ma'am.
Just call the audiovisual guy. I think the frequency is increasing. Yeah, can you? Yeah, please go ahead.
Shall I start now?
Yeah,
Okay.
please.
Okay. So there was a positive history of headache and 2 recent episodes of syncope. There was no associated history of muscle weakness. Coming to the past medical history, she was diabetic and hypertensive. General examinations and systemic examinations were within normal limit. Coming to ocular examination, her right eye visual acuity was finger count 4 meter and left eye was finger count 3 meter.
There is some serious problem, I think, in this
Audiovisual.
screen on this side. Can you please rectify it once forever? Or should we turn on that side? Excuse me. Yeah, that's better, I think, because the. Can we shift the table on that side? Mili, we are sorry for the interruption.
No, ma'am.
You can, take a deep breath. Excuse me. Either you sort it out once for all, or we move the table on that side. Whatever you say, because the moment you go out, the light is going out. Give me your number. Is a number? I think I might be having your number. There is no missed call. Can you please wait for some time? Excuse me. Can you please wait for some time? Or we shift the table on that side because it will again go, and Miri will be very upset with us. Please carry on.
Ocular examination revealed a distant visual acuity of finger count 4 meter in the right eye and 3 meter in the left eye, not improving with pinhole. The right eye showed severe ptosis with corneal sensations intact in both the eyes. MRD1 in the right eye was minus 4 mm. Pupil were reacting to light in both the eyes.
Yeah.
Next slide.
Next.
Extraocular movements were restricted in all gazes except in lateral gaze and full and free in all gazes in the left eye. There was a mild exodeviation of 15 degree. Fundus findings were within normal limit. The lens was cataractous in both the eyes. Coming to investigations, revealed ppbs of 256 milligram per dl, and HbA1c of 8.3%. So this was a case of uncontrolled diabetes. We also went on with MRI brain, which in turn showed ischemic demyelination in the bilateral basal ganglion and involvement of periventricular white matter and cerebral edema. Then, with the MRI brain, we found a very interesting finding. It was the case of missing arteries in both the cerebral hemisphere, bilateral posterior communicating artery agenesis. So concluding this, so this is a case where there is bilateral posterior communicating artery agenesis, which in turn is compromising the posterior circulation. That in turn is predisposing this female for recurrent episodes of acute ischemic strokes. Also, this female is suffering from type 2 diabetes mellitus, which itself is a contributing factor for ischemic nerve damage. So what do we conclude? The oculomotor neuropathy in turn here is resulting due to pupicoma agenesis and type 2 diabetes mellitus coexisting together. But how does it differ? Here, in this case, we have to treat the patient with initial dose of steroids and then followed by conservative ways of the way we manage diabetic neuropathy patients, which includes strict glycemic control, lifestyle changes, and educating the patient regarding the same. This is the 3-month follow-up picture of the patient. Patient was on regular insulin, Glargine, OHAs, and aspirin and atorvastatin. Thank you.
Thank you. Any
Thank
question,
you very
madam?
much. Yeah. Is there any correlation between the duration of diabetes and the onset of this, artery issues that you were talking about? Is there any correlation?
Correlation between
the duration of diabetes?
Yes, ma'am. Yes, ma'am. Yeah. There is a correlation. It is more in. It's most commonly seen in type 1 diabetes, and with the duration, as the chances of retinopathy also increases, neuropathy also increases.
Thank you.
There was no TIAs or there was no vascular events before this? Patient did not have any
Yes, ma'am.
history?
I mentioned in the slide. There was an episode, 2 episodes of syncope,
yeah,
an
you
episode
said.
of headache.
Okay. So thank you.
Okay, thank you, sir.